In this section, we will talk about mechanics of cardiac muscle. This chapter is about mechanics of cardiac muscle, and the first thing we can think about is the idea of systolic performance of the ventricle. All right, what does that mean? Systolic performance simply means the overall force generated by the ventricle during systole. That's it. The overall force generated by the ventricle during systole. Now, two big things to remember. Start from the most simple element. Very, very fundamentals. The heart does two things in systole. It pressurizes and ejects. Just stop, think about it, and incorporate that in. During systole, when the heart contracts, what does it do? Very fundamentals. It pressurizes and ejects. Put that in your core, in your basic understanding. We'll start very simplistically. Pressurizes and ejects. Now, for diastole, if we think about what occurs in diastole when the heart is relaxing, we can again simplify it down to its very fundamentals. In diastole, it will depressurize and refill. So during diastole, the heart will depressurize and refill. So just put this as your very, very fundamentals. And then what we can do is we can start adding in and building upon this idea. So during systole, the heart does two things, pressurizes and ejects. During diastole, it depressurizes and refills. Now, the thing to remember is what's going to influence one of the factors, and this will actually relate to contractility in just a moment, which we will discuss in more detail in just a moment. An important factor influencing this systolic performance, again, pressurization and ejection, would of course be the number of cross bridges that are cycling during contraction. More cross bridges cycling, greater force of contraction. What's going to generate more cross bridge cycling, as we'll discuss in more detail in just a moment? Providing more calcium. All right, remember, calcium binds to troponin C and allows the interaction of actin and myosin. All right, this systolic performance is going to be determined by three things. So for any given heartbeat, we have three key things that are going to influence systolic performance. These are preload, contractility, and afterload. It is a recurring theme when you talk about pump function. Contractility, afterload, and preload. And I've given you a little mnemonic for this. Notice what came in the lower right-hand part of the slide, CAP. This is a mnemonic for you to remember. What I want you to do is tip your cap to the ventricle for keeping you alive. Contractility, afterload, and preload. Slightly different order than what's on the slide, but that's the easier way to remember. Just remember, tip your cap to the ventricle for keeping you alive. These are the three variables, the three factors: contractility, afterload, and preload. Okay, for ventricular mechanics, or the mechanics of ventricular muscle, we'll start first with one of the factors. Remember to tip your cap to the ventricle for keeping you alive. We'll start first with preload. Preload is that load on the muscle before it contracts. Okay, so in other words, in the relaxed state before it contracts. This load will occur at the end of diastole, because diastole is ventricular relaxation. So preload will be the load on the muscle at the end of diastole. This is very, very similar to skeletal muscle. We talked about in skeletal muscle, preload stretched the sarcomere. Well, we have the exact same thing in cardiac muscle. Preload is what's stretching the sarcomere before it contracts, so therefore it's at the end of diastole. Now, the thing about preload for the heart is we can't directly measure it. So instead we have to use indices. Now the best index of preload for the ventricle is left ventricular end diastolic volume. And hopefully this makes good sense. If we stop and think about it, we have a chamber, a heart sitting inside our chest. It fills up with blood. So what's going to stretch the walls? What's going to stretch the myocyte? More specifically, what's going to stretch the sarcomere will be the volume of blood in the chamber. And so left ventricular end diastolic volume, remember preload is before it contracts, left ventricular end diastolic volume is your best marker, your best index of preload. Now, it's not particularly easy, or it wasn't in the past, to measure ventricular volumes. You can now do it with ultrasound. But nonetheless, we have ways to estimate the volume by measuring the pressure. Okay, because we know that pressure and volume are directly related. So left ventricular end diastolic pressure could also be used as an index of preload. Now, the next ones I'm going to mention, these are less reliable. Technically, they're less reliable, but these are the ones you're going to measure clinically. These are specifically central venous pressure, CVP, pulmonary capillary wedge pressure, which I'll just refer to as wedge pressure, and right atrial pressure. All of these are indicators of preload. They may be less reliable, but these are the ones that are frequently measured clinically. And so for USMLE Step 1, be prepared for measurements or clinical vignettes in which they talk about CVP or pulmonary wedge pressure or right atrial pressure. They're all telling you the exact same thing. They're saying preload to the ventricle. Technically, CVP and right atrial pressure are preload to the right ventricle, whereas pulmonary wedge pressure is preload to the left ventricle, because pulmonary wedge pressure is effectively measuring left atrial pressure, and so therefore it is preload to the left ventricle. But nonetheless, don't get confused. CVP, wedge pressure, right atrial pressure, all of these are telling you the same thing. They're telling you preload to the heart. Here's a picture of that totally cool Swan-Ganz catheter. How do we measure pulmonary wedge pressure? We utilize this Swan-Ganz catheter. Notice that it's yellow and it has multiple ports. And at the very end, you have a balloon that you can inflate. Now, this gets put into a vein, like subclavian vein. And the idea of this catheter is we put it in a large vein, we blow up the balloon, and the balloon helps guide, so to speak, or allows the catheter to advance in the same direction as blood flow. So that was the original idea of the Swan-Ganz catheter. So this balloon, we blow it up inside the vasculature, and then we just advance the catheter following the path of blood flow. So we go from the vein, right atrium, right ventricle, then into the pulmonary artery. And that's what we utilize the Swan-Ganz catheter for, to measure pulmonary artery pressure or to measure what we call wedge pressure, which we'll talk about on the next slide. Here's kind of a pictorial describing what I just indicated. We're going to measure pulmonary wedge pressure. The measurement is at the very tip of the Swan-Ganz. All right, just a little bit in front of the balloon. So we blow up the balloon, we put it in the vein, and then we advance it down into the right atrium, illustrated number 1, where we could measure right atrial pressure if we want. We could just leave it there and measure right atrial pressure. Or we can advance it across the tricuspid valve into the right ventricle, and then across the pulmonic valve into the pulmonary artery. Again, that balloon helps direct it. Then what we do is we wedge it in a small pulmonary artery. That's second bullet point. We wedge it into that small pulmonary artery. We blow the balloon up, and this stops the blood flow to that area. Therefore, as illustrated on point number 4, we are measuring the pressure downstream from the Swan-Ganz. What's downstream? If we're in a small pulmonary artery, pulmonary capillary. So we're measuring technically pulmonary capillary pressure. But this pulmonary capillary pressure is going to be very close to left atrial pressure. So we utilize pulmonary wedge pressure as a marker of left ventricular preload. All right, quick review from skeletal muscle on the left is our length-tension relationship. On the x-axis is sarcomere length, or preload. Remember, preload determines length. On the y-axis is tension. We have two different curves, but the one we're very interested in is the active tension curve. But notice, if I'm at, notice the arrows, if I'm at a certain level of preload, I have a certain length, and I get a certain level of active tension. If I increase the preload, then notice active tension goes up, and it continues to go up until a certain point. Thereafter, when I increase the preload, then notice that active tension begins to fall. So this is our bell-shaped active tension curve demonstrating the length-tension relationship in skeletal muscle. Okay, that was just a quick review. We went through that in skeletal muscle. Cardiac muscle has the exact same thing. We just don't call it length tension. We call it the Frank-Starling mechanism. All right, so Frank-Starling is the length tension relationship. So the x-axis is preload, left ventricular end diastolic volume. Now, as we said on a previous slide, we have a lot of other indices of preload, and be prepared for these on step 1. We can utilize right atrial pressure, we could use pulmonary wedge pressure, we could use CVP. Again, they're all telling you the same thing. They're telling you preload for the ventricle, preload for the pump. We don't put tension on the y-axis like we do with skeletal muscle. Instead, we put an index of tension, stroke volume. But we have other indices of tension. Remember systolic performance. What does the ventricle do in systole? Two things, pressurizes and ejects. So stroke volume represents ejection. We could just use the term systolic performance, which means both pressurization and ejection. I could also use cardiac output, because cardiac output is simply stroke volume times heart rate. And then, since it pressurizes, I could also use peak systolic pressure. So notice, x-axis, preload, we have a lot of indices we can use. Y-axis is just tension, but we don't put tension on there. We put a marker of tension, stroke volume, systolic performance, cardiac output, peak systolic pressure. All of these are viable. All of these are very viable for a y-axis. Now, what we're interested in, as I indicated before, is the active tension portion. Notice what the Frank-Starling mechanism is telling us. It's saying if we start with this preload or this volume, we'll just pick a point. Notice we get that stroke volume, or it could be a certain peak systolic pressure. What Frank-Starling is saying is if I increase preload, I will increase ejection. All right, let's stop and think about this for a second. In short, what the Frank-Starling mechanism is telling us is that if I give the heart more blood, it pumps more blood. Notice how we move up the active tension curve during systole, the green line. So I give the heart more blood, it pumps more blood. If I give it less blood, it pumps less blood. The heart, the heart is great. It's wonderful. We love the heart, right? And, even on Valentine's Day, it's heart. You touch my heart. And the heart is critically important, but the heart's not all that smart. It's just a pump. So you give the heart more blood, it says, hey, okay, I'll pump more blood. But if you give it less blood, then it pumps less blood. If the heart don't get it, the heart don't pump it. That's what the Frank-Starling mechanism is all about. Now, this is the P in CAP. Remember, tip your cap to the ventricle for keeping you alive. Contractility, afterload, and preload. So the P stands for preload, right atrial pressure, CVP, pulmonary wedge pressure, etc. This is a very important relationship. Frank Starling is crucial for understanding cardiac functions. Now again, and I'm not going to draw it on the graph, but if you give it too much preload, remember the active tension will start to fall. So if I overfill, so to speak, the heart, then stroke volume will go down. In general, that doesn't normally occur, not physiologically at least, but it can pathologically. The key thing physiologically for the heart and Frank Starling is simply if I give the heart more blood, it pumps more blood. If I give it less, it pumps less. That's Frank Starling. It's linked tension for the heart. Okay, that was preload. Now let's talk about contractility. And another term we can use for contractility is inotropic state. Contractility is a change in performance at a given preload and afterload. So in other words, a change in force of contraction at any given sarcomere length. So in other words, this is a change in performance. Could be stroke volume, could be peak systolic pressure, etc. A change in performance without changing preload. Notice at any given sarcomere length. Again, preload influences the length. So contractility, or in other words, another term for that is inotropic state, is a change in the performance that is independent of Frank Starling. So in other words, a change in performance at a given preload and afterload. What's going to change the inotropic state physiologically? A big one is, as we indicated before, calcium. Give more calcium, more crossbridge cycling, greater force of contraction. So acute changes in contractility are due to changes in the intracellular dynamics of calcium. All right, let's stop and think for a second. Let's kind of go off the book. What are my endogenous compounds that are going to increase contractility? Endogenous compounds. Hopefully you said norepinephrine and epinephrine, both working at the beta-1 receptor. Remember that beta-1 works through GS cyclic AMP. Norepinephrine from sympathetic postganglionic nerve terminals, epinephrine from the adrenal medulla, both bind the beta-1 receptor, and this can increase contractility. Signal transduction is GS cyclic AMP. Those will be our key ones physiologically. Now, some drugs can increase contractility as well. And how are they going to do that? Provide more calcium and provide it at a faster rate. We said drugs. Talk to me, pharmacology. Tell me about some drugs that increase the inotropic state. Hopefully you said beta-1 agonists. Beta-1 agonists like dobutamine. Also, dopamine can do it. It's not working through beta-1, but it's going to act like a beta-1 agonist. So if I activate beta-1 receptors with a drug, I'm going to do the same thing that I do physiologically with epi or norepi. Another drug that can bind to beta-1 and increase contractility is isoproterenol. But isoproterenol is not a selective beta-1. Dobutamine is, but not isoproterenol. Isoproterenol is a non-selective beta-1, beta-2. Now I know when I said drugs, a lot of you said dig. Yeah, digoxin, no question about it. And we have to remember, what is the mechanism for digoxin? Blocks the sodium-potassium ATPase, which ultimately provides more calcium. We also have a couple of other drugs that are used. Can we think of the drugs? Enomerenone? Did you say enomerenone? Milrinone? These are phosphodiesterase inhibitors. By blocking phosphodiesterase, they increase cyclic AMP, and they can also be utilized as inotropes. It's always good to integrate and think, and we'll do that a lot throughout this. All right, because I get more calcium, I get more cross bridges, If I get more cross bridges or cross linking, I will generate a greater force of contraction during systole. Now, when we get chronic losses in contractility, this is due to myocyte dysfunction, and it's rarely related to calcium dynamics. So contractility is our other player influencing systolic performance, and they're directly related. And again, inotropic state. So an increased inotropy means increased contractility. Decreased inotropy means decreased contractility. Okay, because contractility is so important, we need ways to determine what's the patient's contractility. This is pump function. This is huge. It's critically important, not only physiologically, but for medicine, and thus for USMLE Step 1. One index of contractility is something called dP/dt. dP/dt stands for the change in pressure over the change in time. All right, in other words, it is the rate of pressure development during pressurization, which is isovolumetric contraction. Another one that you're going to use and see a lot on Step 1 will be ejection fraction. Ejection fraction is a marker of contractility. Ejection fraction is calculated as stroke volume divided by end diastolic volume. Now let's think about what that says. End diastolic volume is how much blood I have before I contract. Stroke volume is how much blood I eject out. So in other words, it's what fraction or what percent of the blood in the ventricle gets ejected. That's ejection fraction. So if ejection fraction goes up, that suggests an increase in contractility. If it goes down, that suggests a decrease in contractility. Ejection fraction will be a big one for you for USMLE Step 1 because ejection fraction is your clinical marker of contractility. All right, it is your clinical marker of contractility. So if contractility goes up, that means ejection fraction will go up. So when you measure or determine an ejection fraction, if it goes up, in general, we think increased contractility. All right, now, technically, it is not a pure marker of contractility because it is influenced by afterload. But nonetheless, clinically, USMLE Step 1, ejection fraction, marker of contractility. All right, marker of contractility. Ejection fraction is your clinical marker of contractility. All right, so another marker of contractility will be item number 4 here. But before I go into that, let's step back and look at it. The solid lines represents a normal heart. We're going over 2 cardiac cycles, pressure, and we're just measuring pressure. So first phase of systole, we pressurize. We're not measuring the ejection here. Then during diastole, we depressurize. All right, so we have 2 cardiac cycles. That's the solid line. We pressurize, depressurize, then pressurize and depressurize. Now we hit the heart with a beta-1 agonist like norepinephrine, dobutamine, epinephrine, etc. That's what's represented by the dashed lines. Notice the change in the pressure wave after giving the beta agonist. And we can label 4 different things on this. And we'll review it again after this slide. 1 represents dP/dt. This is the rate of pressurization. Notice that with a beta agonist, it pressurizes faster. 2 is peak systolic pressure. Notice that peak systolic pressure goes up. 3 is rate of relaxation. Notice that the heart relaxes faster. All right, quick pop quiz. Can we remember what causes relaxation in striated muscle? 5 letters. And if you said CERCA, excellent, because CERCA is what pumps calcium back into the SR and is responsible for relaxation. Item 4 is something we call systolic interval. And that just means the time in systole. All right, now, notice, contracts faster, relaxes faster, and we have a bigger peak systolic pressure, which means systolic interval went down. So we had a decrease in systolic interval. All right, this is, item 4 at least, is a marker of contractility. Let's step back. Quick review. If I give the heart more blood, would peak systolic pressure go up? In other words, number 2? If you said yes, excellent job. So, peak systolic pressure, if I were just given this pressure trace, example on a question on step 1, and I see an increase in peak systolic pressure, well, that could be a Frank-Starling mechanism. That could simply be increased preload. Could be increased contractility, or it could be both. But the point is, I can't distinguish if item 2, peak systolic pressure, I cannot distinguish if that's an increased preload or an increase in contractility. On the other hand, systolic interval goes down if I increase the inotropic state. So a decrease in systolic interval tells me an increase in contractility. That tells me it's not a Frank-Starling mechanism. And it can be important for us to separate whether a mechanism is Frank-Starling or a mechanism is contractility. In other words, if heart function changes, peak systolic pressure, well, that could be Frank-Starling or contractility. But if it contracts faster and relaxes faster, then that's a change in the inotropic state, not a Frank-Starling mechanism. In other words, Frank-Starling may generate a greater pressure, but it won't cause the heart to contract faster and relax faster. And that's a key point. Again, we have to know, think about, and assess the inotropic state of the heart. Very important to distinguish this clinically and thus on USMLE Step 1. So as I indicated, we would go back through these again. On the previous slide, item 1 was DPDT. Notice that the slope increases, so it contracts faster. Item 2 is an increase in peak left ventricular pressure, and that's due to a more forceful contraction. An increase in contractility means a more forceful contraction. There was also an increase in rate of relaxation. That was item 3. This is related to the rate of calcium sequestration back into the SR, which is done by CIRCA. And then finally, decreased systolic interval. This is your marker of contractility. It contracted faster, relaxed faster, therefore systolic interval went down. This is a marker of the inotropic state. Systolic interval is not influenced by Frank-Starling. All right, let's talk about the idea of the other interval, diastolic interval. Heart rate determines diastolic interval. All right, let's stop and think about that for a second, why that is. Time in diastole, that's what diastolic interval means. So the lower the heart rate, the more time we spend in diastole. So heart rate and diastolic interval are inversely related. Heart rate goes down, I spend more time in diastole. Heart rate goes up, I spend less time in diastole. Think about the amount of time you have in diastole if you're beating at 60 beats per minute versus 120. So heart rate and diastolic interval are inversely related. Sympathetics are going to decrease both systolic interval and diastolic interval, as we just went through. Systolic interval is decreased when I increase the inotropic state, or in other words, increase contractility. That's because I'm contracting faster and relaxing faster. But also, sympathetics, beta 1, GS, cyclic AMP, increase heart rate, therefore they decrease the diastolic interval. Now, diastolic interval is important. And the reason diastolic interval is so important, can you tell me? Oh, I heard you shout out. You're absolutely right, because this is time for filling. I need an adequate diastolic interval in order to fill. I do two things in diastole, my heart does. It depressurizes and refills. Next aspect for the heart, we did contractility, we did preload. Tip your cap to the ventricle for keeping you alive. Now let's talk about afterload. Afterload is that load that the muscle works against. We discussed this in skeletal muscle. It's the exact same concept in cardiac muscle. All right, the load that the heart must eject against, or the load that the heart must work against. All right, so what is afterload to the heart? Well, this is very, very controversial. But probably the best marker of afterload is total peripheral resistance, abbreviated as TPR, total peripheral resistance, or also called systemic vascular resistance, SVR. If we stop and think about it, the heart has to eject blood, and the idea is we want to put a flow into the systemic arteries, but what's working against that flow? Well, the resistance. So probably the best marker of afterload is TPR. Again, it is controversial. Now, the other thing about TPR is it's not routinely calculated. So, instead, what's often used clinically as a marker of afterload is arterial pressure. Some people like diastolic, some people like mean, some people like systolic. But the point is, and we will discuss when we get to hemodynamics, resistance and pressure are directly related. So we can utilize arterial pressure as kind of an index of afterload. It's not as accurate, but nonetheless, it is what we utilize clinically very, very often. And that's because blood pressure is so easy to measure. All right, when are we going to have increased afterload? Well, if aortic pressure goes up. Hypertension, for example, often associated with elevation and resistance. Resistance goes up, pressure goes up. So hypertension increases afterload. This makes the heart work harder. It has to work harder to overcome that afterload. Anything that increases systemic vascular resistance or total peripheral resistance will also increase afterload because that's our best marker of afterload, so hopefully that makes good sense. Aortic stenosis is another very important one to remember for USMLE Step 1. Aortic stenosis is a big increase in afterload, and so it is a pressure overload of the left ventricle. As we will discuss in a little bit more detail again, we'll talk about the idea of a pressure overload for the left ventricle. So aortic stenosis would represent an elevated afterload. Now, when afterload goes up, stroke volume falls. And if stroke volume falls, then in-systolic volume will go up. I get less ejection. And let's think about that for a second. Make it make sense. If I increase the afterload, then I can't eject as much blood. It's like going from trying to lift, 40 kilos to 60 kilos. Can you move your muscle as much? Can you shorten your muscle as much? Maybe not. Maybe you're strong enough to, but maybe not. If that afterload gets very high, the muscle can't shorten. You get an isometric contraction. Well, we don't want an isometric contraction in the heart, okay? Because then that's all pressurization, no ejection. That's no ejection. So we clearly don't want that. So there's an inverse relationship between afterload and ventricular output, more specifically stroke volume. Afterload goes up, stroke volume falls, and vice versa.